soon to be ex-Vice President of the AMSS. Yeah, I think this is a time of great change that will have ramifications for medicine at the University of Adelaide for many years to come. So it's really pleasing that so many of you are happy to come along tonight and give up your time to hear more about these changes. So with us we have Professor Randall Faull, who's the Deputy Director and Deputy Dean and Director of the Medical Program, and Professor Alastair Burt, who's the Dean of Medicine and Head of the School of Medicine. And they're giving up their time to speak to you tonight about the new strategic plan for the medical program. So please join with me in making them feel welcome. So basically what will happen is that Prof Faull and Prof Burt will give a presentation just summarising the key aspects of the strategic plan, and then after that there'll be an opportunity for you guys to ask questions and make comments, and I'll sort of facilitate that part. I think we can have a relatively informal session. So thanks again, and over to you, Prof Faull.
Thanks, Tom. So I've put together some slides which are deliberately fairly sparse, but I'll talk to them. But I guess probably work best if we both can talk and then we'll have questions at the end. And I'm going to concentrate on things that are happening nowish. Professor Burt's going to talk a bit more about the future plans, but there may be a little bit of overlap, but hopefully not too much. So, okay, so just to fill people in, and I know a number of you will know this already, but there have been some important additions to the academic staff in the Medicine Learning and Teaching Unit, which, as you know, is the unit that drives the program and pulls it together. And to a degree, some of these have come from out of the AMSS review we had a couple of years ago. So those of you in year 1 to 3 would be aware that Dr. Andrew Lynn, who had previously worked at the MLTU in a slightly different capacity, he's come on board as a year 1 to 3 coordinator. More recently, we've appointed Dr. Felicity Ng, who's a psychiatrist, as a year 4 to 6 coordinator. She's 0.6, I think it is, in year 4 to 6. She's based in the MLTU during her university time, and then also works as a consultant liaison psychiatrist. Late last year, we appointed Dr. Helena Ward, who's a full-time assessment academic, which has filled an important gap in the program. Have someone whose primary focus is on assessment and the academic side of assessment in particular. In recent times, there have been some changes to the simulation setup and downstairs in the North Medical School. Dr. Simon Patton has come along to head the facility there. Also, late last year, we appointed a full-time evaluation officer, Dr. Lynn Raw, who's she's now just had a PhD accepted, and she's been doing a lot of work with the AMSS and other groups about the evaluation of various parts of the course. And also, some of you would have met Ray Peterson, Professor Ray Peterson, who was involved with the course when it first became what was called Curriculum 2000, and went to Queensland for a number of years, and he came back initially to help set up the international MD, which has now been put on hold, but he's getting increasingly involved in the actual undergraduate degree, and that's one of the things he's doing. He's heading up the new evaluation committee. So these are very important additions to the academic staff profile. Another important change that's occurred this year is that the MLTU has moved into the School of Medicine. Now, that may not seem that important, but it's actually led to some useful and significant improvements, I think, in the way that things work. So, for reasons that are don't really need to go into, the MLTU actually sat in a different school, the School of Population Health. But this year it's moved to the School of Medicine, and so there are some very important byproducts of that move. One is that the School of Medicine is the largest school that is involved in the course, and so that means there's a lot more opportunity for close work between the MLTU staff and the School of Medicine staff. Secondly, one of the important things that came out of the appointment or the creation of the full-time Dean of Medicine position, which Professor Burt holds, is that that person should also be the head of the School of Medicine. So what that means is now that the person who is the head of the school has direct responsibility also for the main teaching program in that school, which didn't kind of happen before because the medical program sat across 4 different schools. So that's been, I believe that's been a very important move forward, and I think we are definitely starting to see the benefits of that new arrangement. A number of you would have been a bit involved with the AMC review that occurred 2011. There's some headaches, I can't remember how far I'll go. I was in there for a long time. Anyway, we've had a number of interim reports since then, which we've had encouraging responses to. They've been pleased with the changes, some of the changes that I've already outlined, they've been pleased with. We have another visit planned for next year. That's not avoidable. At some stage, at least I naively thought we maybe could avoid another visit, but we can't. So another team will be coming about the middle of next year. At that time, we will, or leading up to that, we need to put in another report, but we'll be clearly flagging to the AMC our intentions to move to an MD degree, and Professor Burt will talk a bit more about that in his little presentation. And the students will also be involved in the presentation of the AMC review at that time. Those of you who haven't been involved probably should know that this is an awful lot of work. Those who have been involved know there is an awful lot of work doing these things, but it is important that we get the further accreditation of the course. Students, I think, very understandably always want to know what's happening with student numbers for a range of important reasons. And these are the approximate numbers that we have in the course now. At the moment, we've just ticked over 1,000 students in the course, and the intention is to keep it at that level, more or less, for the time being. The number of students, there's been a catch-up period. So last year we graduated around 130 students from Year 6. This year it's around about 150. Next year it'll be about 190, and that it's an approximate plateau at that until the current first years, which was deliberately a smaller intake of around about 150 students come through. And the plan at the moment is to have the intake being approximately the same, at least for the next 2 to 3 years, but possibly long term. And I apologise for being vague about that, but it's actually not as straightforward as people think. It's not just a matter of picking a number and sticking to that number. It's all to do with how many students graduate, how many can come in at the bottom end. Because the number of places that are funded in the course is for the whole course. It's not funded per year. And it also, the number of students in each year fluctuates quite a lot, surprisingly amount, I think, you'll find if you look at it, with students, some students taking a year off to do honours, other students coming back, some students failing, other students repeating, passing, whatever. So we get quite large fluctuations. It's not exactly the same from year to year. The key thing about this is how we've been able to cope with the increased number of students that are coming through. This is wave of increase or plateau of increased number of students coming through. And next year, in 6th year, is the first year that we'll have to deal with the 190 students that we've been dealing with in years 3, obviously 2, 3, 4, and 5 for the last few years. And there have been significant pressures. So for next year, for year 6, the biggest pressures were on surgical intern places, and also emergency department and intensive care. I'll talk a little bit about some of the changes we made, but in year 5, 4, 5, there have been pressures in various areas, and those of you who are in those years would be aware of the consequences of those pressures. So it's been quite a challenge to maintain an even mix of quality for students across these various attachments. And I have to say, I think on the whole we've done well. I think we've done as well as we reasonably could have under the circumstances, and the general, almost without fail, the clinical title holders do a lot of the clinical teaching have done a great job. It's very unusual for them to say no if we ask them to take a few more students, so they really went out of their way to accommodate us. But the pressure will gradually diminish over the next few years, which will be nice. An important change that's relevant to all students here, except those of you who are in 6th year, is the change to the what used to be called the supplementary examinations process. You'll know that, because you've been through exams, unless there's first years here as well, that the medical program has had an exemption from academic subs for some years. And I won't go into the reasons behind that, but we've had supplementary examinations for medical and compassionate reasons, which is not unreasonable, obviously. But we've had an exemption from academic supplementary examinations. Now, that is changed. We have changed to being to fitting in with university policy to have the equivalent of academic subs. And they've actually changed their name, and I hope I got these names right because I always get confused. The academic subs, what used to be called academic subs, are called additional examinations. This is correct, isn't it? And the medical compassionate subs in the future are going to be called replacement examinations. And so this year, students who in the past, if they had a D in an examination, were a single D, were passed for the year. Now, if they get a single D, they receive a sub. And if they fail that sub, they fail the year. So that's the consequence. And what it means is that we'll have a lot more supplementary examinations at the end of each year than we have had in the past. Now, this is a major logistic exercise, and we've been trying to predict how many examinations we'll have at the end of the year based on how many Ds have been in previous years. And when we looked at that, we decided that the simplest thing to do was to combine them all together, so there'll be single supplementary exams at the end of the examination period to cover both the replacement and the additional examinations. And as I said, it's a lot of work to create these extra exams, but that's the way things are at the moment. Just thought it's important, those of you who are going into Year 6, there's some significant changes for next year that most of you probably are aware of, but I just thought it was worth reminding you, and also those of you in the earlier years, just to let you know. So we have created some new surgical internships to accommodate the increased number of students. The surgical internships was probably the one that was most challenging to find us. We converted some SCAPs into surgical internships. Now, the main one that's been changed is the cardiothoracic SCAP at the Royal Adelaide Hospital, okay, which, when you think about it, has been probably an ideal surgical internship for some time. It's got 3 interns in that unit. They see a lot of general medicine anyway, a lot of people with diabetes, vascular disease, and so we've converted that into an internship for next year. We also, the other area that we were short of places was in emergency departments places, and so this was difficult as well, but the Royal Adelaide Hospital primarily, the people who run the acute medical unit, including Joe Thomas and Campbell Thompson, have come up with a system where we're now going to have students who will spend some time in the acute medical unit of the Royal Adelaide Hospital as part of their ED rotation. So I can't give you the precise details of how they're going to allocate students, but basically we'll be using the emergency department, the intensive care unit and the acute medical unit as part of this emergency or acute care medicine rotation. In fact, I think we probably should be talking about that being more of an acute care medicine type of internship rather than just an ED internship, which is what's traditionally called. We've just agreed in the last week or so to a new SCAP in simulation medical education, and so Simon Patton's got a very nice proposal for a SCAP, and you will all be aware that there's a medical education SCAP which is very popular. This will be an additional medical education SCAP, but we'll have a focus specifically on simulation. Next year the teaching arrangements in Year 6 will change. Instead of being a half-day teaching and then a 2-week core skills block, the 2-week core skills block is no longer existing. It's going to be a full-day teaching day in the internship block. Each Wednesday the students in Year 6 in the internship block will be here at the Royal Adelaide Hospital on this campus having a full day of teaching, which will combine the elements of the previous half-day formal teaching as well as elements of the core skills, practical skills. And Joe Thomas is the person who's mainly involved in organising that. We've also changed next year the Dean's Elective, which has been in existence for decades, and has always been between 5th and 6th year. We've made a change, but that's now incorporated formally into the Year 6 block. It's also, for various reasons, the name has been changed to a student-selected experience, and students can take it now at different times during the year rather than a fixed time in between 5th and 6th year. The issues I thought with assessment that have come up, the main ones that have come up have been the Year 4 musculoskeletal term, issues about balance between formative and summative assessment and amount of assessment, and there's a plan to, there's been some changes made, and there's a plan to then review that again at the end of the year to see if the changes that have been made in the last couple of rotations have helped to alleviate the problems that were picked up in the first half of the year. And also there's an issue with the Year 5 geriatrics GP term where the different sites in geriatrics are using different assessment systems, and we've got a plan to try and address that, although we can't change that for this year. I think the thing that comes up most regularly in terms of delivery of the program is probably continues to be the anatomy, pathology, histology, which has in various ways has been an issue since I've been doing this job, so it seems to sort of come up every year as something that needs to be changed. There's various issues, online versus didactic lectures, the quality of lecture material and the delivery, and also the old chestnut of whether students need to do dissection or not as part of their anatomy learning. Just a couple of positive things to almost finish. A number of, probably most of you should be aware that the new prize has been created this year, the Hugh Kildare Prize, which will be awarded for the first time this year, which will be for the best student in clinical skills in years 1 and 2. And the plan is to judge that prize at the end of this year, but to award that prize at the start of year 3 next year, and 4 yet to be decided. And to remind those who wouldn't have been aware, except for a small group, that we reinstated a prize, the Craddock Prize, which had gone into abeyance for a number of years for some various reasons. It was reinstated this year and is for, I've actually written that incorrectly, it's for clinical skills in year 3. It's awarded at the start of year 4, and it's for the best student in the end of year 3 also. So that's 2 prizes looking specifically to recognise quality in the area of clinical skills. Every time I get a chance to stand up, I like to talk about the foundation. Medical Students Foundation, which you as a group you should be extremely proud of. This is a unique initiative in this country. It's very student driven, it's got some postgraduate guidance, so I'm privileged to be the current chair of the board of that, but basically the students do all the work. Professor Faull and I, a couple of other people sit around and try to say smart things, but the students do all the work. It's steadily accumulating funds, and I expect that you'll see that over the next few years we'll do more and more things for the students, and that's been a great initiative. And that was a way to say, but I'll happily take questions and comments after Professor Burt.
We won't bother. I think it's because it'll pick it up.
Well, thank you. I'd like to reiterate what Tom said at the beginning. Thank you for giving up your time this evening to come and hear us talk about the programmes, and hopefully there'll be plenty of time for a discussion, as we said, at the end. So, as you've just heard, those of you who didn't know previously, I'm fairly new here. Actually, it's too long now for me to say I'm still the new dean. However, I just got here at the beginning of the year. Before I arrived, of course, I did my homework. I had to find out about what Adelaide Medical School was all about, and it is one of the longest established medical schools in the country. In fact, it's the third oldest, and this is the first set of graduates, and it was, I think, the second university in this country to have female graduates. So a long history. Initially, very small classes, for a very traditional base the students came from, and now a very diverse base, and the student numbers, the numbers graduating, as you've just heard, has increased quite significantly. And as you've heard, it will sort of plateau, it has risen, and it will plateau and fall a little. And of course there are, I'm sure you could quote all of this to me, but there are 2 Nobel Prize winners, previous graduates, and a whole host of Rhodes Scholars and people that did other exciting things with their careers. So again, lots to be proud of, and a strong history. And a strong presence internationally. University of Adelaide Medical School is well known internationally, and currently has about 1/5 of its intake comes from other countries, primarily from Southeast Asia. And since the beginning of 2000, we've graduated 400 international graduates from an astonishing 33 countries. So when I arrived, I guess I would summarise the position by saying that this is a long-established programme, high-quality graduate outputs. Many of the graduates are currently serving within South Australia, but others are across interstate and overseas, and supplying a very high-quality healthcare workforce. And we continue to have a popular course, and the 8R scores of those entering the programme are astonishingly good. It remains an undergraduate school leaver entrance type degree, as you know. That is becoming increasingly unusual in Australia, and we'll come back to that in a moment. But whenever I got here, it became apparent that one of the really successful elements of the course was that there is a strong emphasis on clerkship and shadowing in the later years, in particular year 6, and the idea that you have a barrier exam at the end of 5th year, and then you have 6th year to consolidate and really make yourselves work ready. That to me is an ideal situation. And I think that it's my perception anyway that within the course there are some good elements of student choice. You get to choose MSAs and SCAPs, so there are elements that you have a say over what you're going to do. And by and large, there's been some fairly good student satisfaction about what is delivered in the programme. Not entirely, and Professor Faull has already alluded to one or two of the areas that are concerns, and keep coming back about assessment and about histology and pathology and so on. And you've also already, those of you who weren't really aware of it, you've heard from Professor Faull about the AMC report in 2011. It did identify that there were a number of things that needed to be attended to, and I think we have attended to these pretty well. And as you've just heard, the AMC in their response to our interim reports have been pretty positive. There are still some things that need to be done, but by and large, most of what were set out in their report in 2011 have been achieved. So I think as a consequence of that, it probably is the right time for us then to consider what we're going to do into the future. Okay, so good history, some things that need to be sorted out after the MC, done most of those. Let's think now where we're going next. Of course, predicting what we need in the future is actually quite difficult. And these are 3 genuine quotations. Some of you might have seen this slide before if they've heard me talk, but these are genuine quotations, and clearly some people like Bill Gates got it completely wrong. There are some things that we know are going to shape the way that you practice medicine in the future. There are a whole host of technical advances that are going to impinge on your day-to-day practice. All sorts of exciting things happening in genomics and transcriptomics. And I have a colleague back in the UK who's got a company now who is setting out to do next generation sequencing at the bedside in the future. So things are really moving on at pace in terms of technologies. Lots of things happening about personalised medicine, the use of digital medicine. Most wards are going to be electronically based in the next few years, and so on and so on. So we can be sure that technical advances are going to have an effect on the way you practice medicine, and therefore we need to factor some of that into our thinking about a future curriculum. But it's not just about technical advances, it's about what society and what employers will be expecting of doctors in the future. And again, excuse me if you've seen these slides before, but I look at these in 3 different phases. There's the old model of medical practice, and do any of you who are film buffs know what film this is?
I do.
Go on then.
That's because I'm older than everybody else. Did you remember the Doctor in the House film?
Doctor in the House, and this is Sir Lancelot Spratt, who was the surgeon in that book and then movie, who would be met at the front of the hospital every morning, coming out of his Bentley, and to be welcomed by all his registrars. And in that sort of model, the surgeons like that were all powerful. They were expected to know everything, the finished article. They didn't have to do any continuing professional development, and they had some fabulous mystical clinical skills. But they were fairly paternalistic in terms of their approach to patients, and generally didn't like questions, being questioned. So things have moved along a lot since then, and the modern model is that the doctor of today is not autonomous. They work as an integral part of teams. They're part of much more complex organisations than Sir Lancelot's hospital. Their practice is much more scrutinised now than in the past. Everything we do in the wards and the laboratories is audited, can be audited, and is regularly audited. And the way that doctors work with patients is now quite different from that paternalistic approach that Sir Lancelot had. Much more of a dynamic interaction with patients. And no longer is it acceptable that someone graduates, gets this enormous, powerful job, and they don't have to read a book again. There is now a very strong emphasis on continuing to develop one's knowledge base and skills. So that's today's model. But then if we look forward into the future, what will the doctor of tomorrow need to be? What are the attributes that we'll be looking for in, say, 2025 and beyond? Well, I think that one of the, and these are my personal thoughts, one of the important elements in the future is that doctors will have to be much more facilitators of patient understanding than at present. And I say that because there's an unfettered access to the internet now, and many patients come up to hospital with some notion about what's wrong with them because they've been on the web and so on. And actually, doctors of tomorrow are going to have to be much better at educating the patients to navigate through some of that information. And that's a sea change from the way that we've interacted with patients until now. They're going to have to be increasingly advocates of healthy living as well as treating disease, much more aware of global and rural health issues, and being able to address health inequalities. And one of the things that I often put in a list like this of attributes is the ability to cope with uncertainty and change. And I say that because we live in a very changing world in terms of healthcare funding, healthcare decision-making and so on. And I think the doctors need to be equipped to be able to cope with some of those areas of change and where there is some uncertainty. And sometimes that's about dealing with uncertainty in just how to manage within the financial constraints individual patients or groups of patients. And then I've talked about technical advances. Now, so just to give you some ideas about where we might need to do things differently in the future, I think over the last decade or more, most medical schools, including this, have quite reasonably focused on improving face-to-face communication skills and active learning skills, listening skills. And I think that was absolutely essential because a lot of the traditional curricula did not really do that to any extent. But as we move forward, actually there are going to be some additional communication skills that the doctors of tomorrow will have to develop. I was in the States about a year and a half ago, 2 years ago, and in one of the big healthcare systems there, the general practitioners were saying that something like 20% of their communication with patients was now by way of email. Now that's a very different environment, and the way you communicate by email is clearly very different from face-to-face. And I've had to deal with all sorts of interesting dynamics between staff that communicate through emails and upset each other. So there's a great opportunity for you to do that with patients and vice versa. So some of the communication skills of the future will have to be different, and will have to be adept at netiquette or digital professionalism. Skip on that. So there are lots of reasons why we should think about perhaps some different content to a curriculum in the future, perhaps some different ways of delivery. And there are some other drivers for change, some of which come from within this university, some come from within South Australia, some come from around the country. If we think first of all around what is the driver for change within the university, hands up those who have not heard of the Beacon of Enlightenment. Good. Good. Actually, that's we can report that back to the Vice Chancellor. Yes, that's the survey. And the Beacon of Enlightenment, as you know, is the Vice Chancellor's vision. It's his strategic plan for the institution as a whole for the next 10 years. And as far as medical learning is concerned, there are a number of important elements, one of which is small group discovery experience, which a lot of what we already do, certainly in years 1 to 3, satisfies the criteria for that, but there may be new elements that we can build upon that will be even more discovery-led. There's a focus on study abroad, not just necessarily the elective period that you have at the moment, but longer periods that might be accessible abroad. And there's a very strong emphasis on excellence and a research-led teaching ethos. So that's some institutional drivers. Then if you look around the